So there are multiple funding sources that are used to purchase the naloxone, and we also make sure that each of our partners submit a monthly report in order to make sure that we can continue to support those efforts. All right, so alongside of of the Department of Children and Families, we can't do this alone, so we have to have our community partners. So first of all, I want to thank the Florida Behavioral Health Association for putting this on, and then we also have a long list of other partners, and not all of them are listed on this slide, but we do really appreciate all of the people who come alongside and support these initiatives in the community. I do want to point out that the Department of Health has the Helping Emergency Responders Obtain Support, which is the HEROES program. This program actually supplies naloxone for first responders, EMS, fire and rescue, and then we supply the community, so we act like a bookend to make sure that all the needs are met in the community for naloxone. We also have the Florida Harm Reduction Collective, which does our mail-based program, so they are the ones that within 24 hours make sure that someone's kit is on their way to them after they receive the request. So, and they are getting a lot of requests every month, so we are greatly appreciative of that. So many others, Florida Sheriff's Association, Florida Perinatal Quality Collaborative, just the list goes on and on. So we truly appreciate all of our partners. So this is just a little bit on the growth of the overdose prevention program. So we started in 2016 with 11 organizations, and we'll use that as 100%. So that was our baseline. Each year, it has just grown exponentially. And this was as of the end of 2022. So it went from 11 to 396. And each year, you can see the compounded percentage increase in the program. So kits distributed, same thing. We started with a baseline, and within the first year, you can see the astronomical growth, and it has just continued to climb. And we're expecting to see the same rate of growth this year as well. And then reversals reported. There again, just continues to expand and increase, and we are grateful that we're able to help save lives in the state of Florida. So we talk about iSaveFL. So if anyone goes to www.isavefl.com, you can click on Find Naloxone in the top left, and you can put in your county, and it should give you a drop down of all organizations that are enrolled to distribute naloxone, not enrolled, but are willing to distribute to people that they're not necessarily serving. So it's not a comprehensive list because not all organizations are comfortable with distributing to the community. They only want to distribute to the people they're serving, but a lot of organizations do want to distribute. So you can find somewhere to locate naloxone in your community for free. So this is a great tool, a great resource. And if you have any questions, you can email iSaveFL at myflfamilies.com with any questions or concerns, and we will get back to you and help you however we can. So we're going to talk a little bit about fentanyl and xylazine. So fentanyl is, as we were talking about earlier, about 50 to 100 times more potent than morphine. And we know the fentanyl analogs are even more potent than that a lot of times. So when we're talking about fentanyl, there's a lot of misconception that naloxone does not work on fentanyl. And that's not true. Naloxone absolutely does work on fentanyl. And it may take more than one dose. However, we don't know a person's history, so we have to start, and then after 2 to 3 minutes, you can administer another dose and continue to move forward. We do have a great overdose recognition and response training. If you're interested in us hosting one of those or linking you to one of those in the community, please reach out, and we can do that as well, and you'll learn further about the actual process of administration. So since there has been an increase in polysubstance use, though, it's really important to understand that naloxone does not work on overdoses that are not opioid caused. So if someone's ingesting other substances, then they may not, the naloxone may not work as effectively. So we want to be really mindful of that. And there's actually several causes that would increase someone's risk of overdose. So mixing drugs and the quality of drugs. So if you are taking benzodiazepines, alcohol, really anything you should check contraindications on, but even over-the-counter medications. It's really important to make sure that the substances are okay to use, and whether that's Tylenol PM or, muscle relaxers. It's important to make sure that those are not gonna cause an effect with each other. So the quality of drugs. So if somebody's buying substances on the street, they don't know what's in it. So they may have been going to the same person for years, but that person gets busted and then they, go to somebody else, or a different supply came in. So they're not, it really does increase the risk. And then low tolerance. So we have jails, we have hospitals, we have abstinence-based programs. People are, their tolerance is decreased. Even after 3 days of not using, someone's tolerance can decrease extremely to where they may get out and go back to trying to use the same amount they were using before their period of abstinence, and that could be enough to kill them. Or there again, they may get a hold of something different than what they think it is. So those are really important things to consider as far as being at risk for an overdose. So Xylazine, this is not an opioid, but this is a substance that we are seeing consistently with fentanyl. Over 98% of the deaths where Xylazine is present, fentanyl has also been present. So when someone is overdosing on a substance that contains Xylazine, it's really important to note that the overdose does not look the same. And the Florida Harm Reduction has a great training on what that experience might look like, but it's important to note that it doesn't look the same. Also, it's not approved for human use, so there's no studies on how this is going to affect people. People in Puerto Rico have been using Xylazine for many, many years, but they typically don't mix it. Here it's mixed with fentanyl primarily, or other opioids, so it's really important to note that this is a really nasty, this substance has a really nasty side effect of wounds on the skin, and it's not necessarily at the injection site, so a lot of people are having to get their limbs amputated. There's been a lot of, a lot of challenges with the wound care, and it tends to respond differently than typical wounds. So whereas typical wounds you want to keep dry and things of that nature, this you have to keep moisturized, and so it's a whole different process. So it's really important that people are getting educated on wound care and Xylazine and the presence of it, because it's not, at this point, not going away. It seems to be just expanding. So it does cause debilitating withdrawal symptoms, which are pretty close to alcohol and benzodiazepine withdrawals, so it can be medically dangerous. So it's really important that our medical professionals are aware of these withdrawals and able to, treat the individuals that they're serving in the most appropriate way. So some tools and techniques that we can do are making sure that we educate the people that we're serving, as well as our coworkers and colleagues. Also, Xylazine test strips for urine. So if people are concerned, if they're consuming Xylazine, they can test for themselves if they are. We want to make sure that people are aware, and it might help them either not use that again or determine that that's not something they want to do. So also pulse oximeters, because the overdose looks different, people are carrying around pulse oximeters. They're only about $10 on Amazon, but you can check someone's oxygen level to make sure that they're getting enough oxygen to their brain as well. CPR rescue mask and resuscitator bags, as well as wound care supplies, and always carry Naloxone. Even if someone's overdosing on a substance that contains Xylazine, it's still important to give them Naloxone, because it can reverse the overdose of the fentanyl, even though the tranquilizer will still be acting and effective. So, all right. So we're going to talk a little bit about adverse childhood experiences and protective and compensatory experiences. So the adverse childhood experience study was done by Kaiser Permanente, and it was a study done, and you can find it on the CDC Foundation website. But basically, individuals who experience excessive amounts of childhood trauma have developmental challenges as well as a lot of additional health challenges later on in life, whether they use drugs or not. So it's really important to note that actually 67% of the population has at least one adverse childhood experience. And people who have 4 or more adverse childhood experiences have 3 times the level of lung disease, even if they don't smoke, ischemic heart disease, 4.5 more times likely to develop depression, 11 times more likely to use IV drugs, 4 times more likely to be promiscuous under the age of 15, and 2 times the level of heart disease. So when we're talking about adverse childhood experiences, domestic violence, substance use, abuse, neglect, emotional, physical, sexual, so having an incarcerated parent, the death of a parent. So there's a lot of significant events that happen in people's lives that we kind of expect them just to get over, but we really don't take into account how it affects our physiological being. So as somebody who scores 10 out of 10 on the ACE scale, I'm an overachiever. I did not understand until I learned about this how important it is, because I used to think what's wrong with me, and now I understand what happened to me. So it's really important to have that understanding. But the good news is, and this looks hard, I mean, you can even see the brain of someone who's been maltreated versus the brain of someone who hasn't experienced maltreatment. So it literally changes the way our brain processes things. So it's really important to note that. However, we do know that there are things we can do to build resiliency and help to counteract the effects of adverse childhood experiences. So that is protective and compensatory experiences. So resiliency, relationships, knowledge, communication, and support. So we want to talk about, the things that we can do. Even having a best friend can help somebody be resilient. Having one safe adult to talk to, having a mentor outside the family, living in a clean and safe home with enough food. How many people think that that's a given, that everybody should live in a clean and safe home with enough food? There are a lot of people who do not live in a clean and safe home with enough food. So just having that one piece of the resiliency puzzle can help children thrive. So it's really important to note that, these may sound like, Mayberry, but it really is important that we build these constructs in our society, because this is overdose prevention, this is suicide prevention, this is prevention in general. So making sure that we are building these supportive constructs around our children is extremely important. Having routines and fair rules at home. So we're going to talk. We're going to talk a little bit about evidence-based dosing methods. So as the prevalence of fentanyl and other high-potency opioids rises, it's really important, and I'm glad they were talking about it earlier on the panel, it's really important to note that and take into account, are we doing the best with the dosing methods? Are we doing what we think we should do? Or are we doing what is proven to be effective and efficient and safe and productive for the individuals that we're serving? So really taking a look at that and doing research is something that we're going to be digging into and doing, because precipitated withdrawal is really concerning, because if someone is having excessive precipitated withdrawals, they're going to be a lot less likely to continue to engage in treatment. They're going to be extremely uncomfortable, and they're going to be trying to get not sick is what they're going to be trying to get. And if they can't do that in front of you, they're going to go do it outside of you. So we need to make sure that we are meeting people where they are, not where we think they should be. And that also includes with our dosing methods and our clinical procedures as well. So medication-assisted treatment, it has been such a blessing, but it's also not accessible to everyone. So people who are incarcerated, people who are in the hospital, people who are in rural areas, a lot of emergency room physicians are not comfortable doing buprenorphine induction, so I'm so thankful for the panel here earlier that was, really giving information on how that came about and how that's working. It is expanding, but it's not expanding fast enough. We really need to dig in and figure out how we can continue to make those things work cohesively. And one of those models is the hospital bridge program, where individuals are inducted on buprenorphine in the ED and then connected with a peer to help walk them outside into the organization that they're going to be receiving further services with. So that model looks a little bit different in every organization, but it's the same concept, not medding and bedding, not giving the medication and putting them out on the street. So making sure that we are actually connecting people with people that they're able to relate to, feel comfortable with, and are going to continue that care outside of the emergency room. So our hospital bridge programs are invaluable, and we are grateful for the expansion that's taking place with those. The jail bridge programs. When people are incarcerated, most of the time they do not have any medication. We are getting better at that. We are working on it diligently, but historically it's not been part of the course of treatment. So now we're working on getting individuals established in care, established with medication while they're incarcerated, and linking them with that peer specialist to be able to continue that care on the outside with the organization that they're going to be receiving treatment through. And I really appreciate the gentleman earlier who was talking about medication for opioid use disorder versus medication-assisted treatment, because some people don't want that therapy component. Is it probably going to be a little bit more effective? Yes, but it's not effective if somebody's not willing to do it. So for somebody to have access to that medication and be able to continue to go to work, live their life, raise their children, and do the things they need to do as a participating member of society, it's really important to have that access. So especially people coming out of incarceration, because we know that they die actually 12 times, they're 12.7 times more likely to die in the first 2 weeks after release from an overdose. So it's really important. Also, mobile buprenorphine clinics. People in rural areas. I grew up in South Alabama. The nearest store was like 1.5 miles or 2, but it might as well have been 200, especially on a hot day. And so if somebody doesn't have transportation, just because you have an MAT clinic in downtown doesn't mean if they live towards the outer city limits that they can get there, especially if there's no public transportation. So having a mobile buprenorphine clinic, and even really a mobile integrated health clinic, to be able to bring these services to people who don't have transportation, who don't have access, those things are so important. So we're really excited about the expansion of these programs throughout the state, and we're just glad to be partnering with all of you. And in case you think I made it up, no, just kidding. So thank you. Thank you to all of our partners and affiliates who continue to help make all of this possible and continue to serve the people in the state of Florida.
Do we have any questions for Jennifer? Does anyone have any questions?
Stay for questions.
Oh, back here. We got plenty of questions. All right.
I was running.
Here we go. Jennifer, you're not done yet. Get back up there.
Okay. They don't let me get away that easy.
I could have just yelled. What's the legal picture, or if there is one, for the mobile MAC clinics? Any barriers that people have encountered, or what have you heard about that?
So I know that our licensing team and quality improvement team, our licensing team is working diligently to address all of those challenges. So if you have any questions, please feel free to shoot an email to myself or anyone on the licensing team. I'm not on the licensing team, but I can connect you. So feel free to shoot an email and we'll get you to the right person. All right.
Now that the Xylazine and fentanyl testing strips have become legal, do you anticipate that those will be made available to the organizations as easily as Narcan has, and like at no cost coming up down the line?
So actually, the Xylazine test strips are not legal to test substances. They're only legal to test urine. The fentanyl test strips are legal to test substances now, so there's a little bit of confusion about that, but you can test urine. So fentanyl test strips were not illegal to test urine, but only to test substances. So that is something that the department's exploring, and there still hasn't been a determination made, but we're hoping that we'll be able to continue to have that conversation and make sure people get what they need. But if you send me an email, I will connect you to an organization that is doing that already, and we can make sure that you get what you need.
Thank you.
You're so welcome.
Hi, Jennifer.
Hello.
Thank you for all you do for us. We really appreciate our Narcan that we get from the department. My question is, we are still struggling to get Narcan widespread in the schools, in the Volusia County School District. So do you have any best practices for trying to navigate some of that barrier? Or can you connect us to somebody that's been wildly successful in getting into the schools? Because our kids are overdosing. So,
Absolutely.
but we've hit barrier after barrier, and some of they claim it's a legal issue, even though it's covered by the Good Samaritan Act, blah, 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 blah. So any helpful tips would be greatly appreciated. Thank you.
So the first course of action would be to contact the Department of Health liaison for the schools. That person has been just really, in each county, has been really just invaluable in helping to facilitate that process. Also, I do have some policies and sample policies and procedures that the Board of Education, Florida Department of Education, has shared, and some recommendations for best practices. So I can send those to you and also connect you to a couple of counties. I think we have 19 counties that have engaged in getting Naloxone in the schools and getting their staff trained. And what we're doing is linking the organizations, or linking the schools with organizations that distribute Naloxone and do training. So then they have those resources in the community to be able to refer those families to when they need additional support. So that's working out really well.
Right, do we have any other, we do have another question.
We're Narcan distributors in Brevard. The Blue Plaid Society is very active in getting Narcan out into our community. We've had some stories of some Narcan resistant cases, and we do want to report to you that one of those happens to be the youth and the trend among the youth inhaling alcohol. They are huffing alcohol out of liter bottles, and they can literally ingest an entire fifth in one huff, and it causes an instant alcohol poisoning effect and overdose. Narcan will not work on that. If you come upon some youth or a person that has in an overdose state, EMS needs to administer adrenaline to come out of that. So just another emerging drug trend.
Thank you. Anyone else have a question? All right. Jennifer's presentation will be put up on the FBHA FATA website, and we want to thank Jennifer again. So hopefully it'll be up on the website by sometime late next week. So I'm going to go ahead and ask my two next presenters, actually three presenters. We have an addition to the program today. We're going to talk, our next program is on community transition initiatives. We have Maggie Aggerton, Bureau Chief, Substance Use Treatment from the Department of Corrections. We also have Debbie Troupe with Substance Use Disorder Manager for the Clay Behavioral Health Jail Bridge Program. And we have Nancy Rice with LSF, who is the SOAR Project Director. They're each going to talk about their programs, and I think Jennifer kind of mentioned a little bit about the Jail Bridge Program. You guys can have a seat. And we're going to let Maggie start this conversation off, and we'll go from there.
Good afternoon, everyone. Thank you for having me today. So as Diana said, I'm the Chief of Substance Use with the Florida Department of Corrections, and I wanted to share a little bit about what we're doing in terms of medication with this particular population. As Jennifer said, obviously with the incarcerated population, we face unique challenges to administering medication. And in Florida, our correctional system, the state correctional system, is the third largest correctional system in the United States. As of this morning, we had about 85,000 people incarcerated and about 150,000 people in the community on some form of supervision. In the most recent data for our population, approximately 60% of the folks that we work with have some form of substance use disorder. And I'm sure it won't surprise many of you to know that we don't have enough funding to serve everyone that has a need, and that is very challenging. So for example, I said 85,000 people, about 60,000 have a need, and on average of the folks that are incarcerated, we serve about 15% of that every year. To give you a little bit of perspective, my in-prison substance use treatment budget going into session was $14 million. We got an additional $3 million this year, which was a big win for us. However, if I was to treat everybody that was incarcerated, it would cost approximately $40 to $50 million a year. So there's still quite a gap. On the community side, it's very similar. 60% of the offenders on supervision have some form of substance use need, as well as we don't have enough funding. Funding is roughly the same for them. We got a little bit of a win this year from the legislature. We got some price level increases for our providers, and we got an additional $2 million to provide outpatient substance use treatment in Florida. So we're really excited about that, but it's not enough, and so we're gonna go back next year. We have plans to turn in a legislative budget request for the opioid response dollars, and eventually, I hope, before I retire, that we will be much better funded and are doing a better job of serving our population. We currently use medication in the community. We receive an allocation for Naloxone, and we have about 8 providers that do Naloxone in the community. I'm very excited to say, after a long time coming, we're planning a pilot on the in-prison side where we're going to do 2 male sites and 1 female site, where we're gonna be able to induct individuals on medication prior to release. We're gonna start with Naloxone. I know you're probably saying that's not enough, I understand, but I have to take somewhat baby steps as we move forward. We're dealing with security folks and other people. We're a large agency, so part of our strategy is a huge education and communication plan for our staff, so we have the appropriate support as we go forward. But I'm very excited because we had planned this about 4 years ago, and then the 2 years that we don't really speak about happened, and so now we're back on track. The other thing I'm really excited about is we've been partnering with the Department of Children and Families. I talk to Jennifer probably every other week about our efforts. We originally had Narcan in our probation offices. This year, through the HEROES grant, we have been able to put Narcan in the hands of all of our probation officers that are out in the field. And we're working right now to get Narcan in the hands of all of our security staff at the prison. Currently, we have them in prisons, but they're kept in medical. Obviously, you know, in an overdose situation, time is brain. So we would like to see our security staff carrying the Narcan so that they can interact as soon as possible and reverse the overdose. So we're very excited about that. Again, I know from some of you in the room, the community is much further along in a lot of places, but we're very excited to see the department moving in this direction and our leadership and all the support that we're receiving. And I think that pretty much covers everything. They have 2 wonderful presentations, but I wanted to share that we are moving forward, and I thank everybody for your support. If anybody has any questions related to the department, I'm happy to answer now or later, or I can turn it over to our next folks.
Do we have any questions for, oh, well, we have one.
Hi, Victoria with New Season. My question is your induction. When were you guys wanting to start that? Like, what's your time frame for that?
All of our procedures are currently under legal review, but the plan would be to do 3 injections prior to release and continue it in the community. One of the difficult things for the department is about 1/3 of our population, we release about 30,000 people every year. 1/3 goes out on probation. The other 2/3, they just release. So it's very critical for us to have that community follow-up. And so we're working to bridge those partnerships with the community. So ideally, we would like to do 9 months of injections out of our budget and then be able to move forward with something else. Also, if we get any additional opioid response, we might be able to increase that.
And then what are you guys doing with patients that are coming in, people that are coming in that are in a program already, but then they become incarcerated?
Okay. So, the standard answer is it's a clinical decision for everybody that comes in what we do with them. However, the tide has changed and our legal department is reviewing. Currently, if someone comes in on medication, we may retain them on medication. However, we don't have a fixed system in place to do it large scale. Right now, very small scale, because we do have some jails that are sending folks to us that are on meds. As short as 6 months ago, they might have been titrated off, and now we're starting to work with them. It's very slow going, but it is going in the positive direction versus the negative.
Are there any other questions for Maggie? FATA will be helping with the training of the staff at the DOC. That's one of our other projects we do. So I will be reaching out as we continue further with this project, trying to gather resources and information so that individuals upon release are getting the information that they need when they return to their home community, because we know most of them do not return to the same location where they've been incarcerated. So they need to know the information that's available in their area. So thank you, Maggie. Appreciate it. All right, and next up we have Debbie Troupe and Miss Rice to talk further about the jail bridge program that they are operating in Clay County.
Good afternoon. Is this on? Okay. I'm Nancy Rice from LSF. I'm the SOAR manager. And I'm here with Deborah Troupe, who's also going to be expanding on her program. I wanted to start this off talking about why this is so important to me, Jail Bridge, and Jennifer Williams gave a great sort of lead up to this in talking about this initiative from the state. This is a really important population to me. As Jennifer stated, this is very high risk for people who discharge from incarceration in terms of fatal overdose, 12.7 times more likely to die of a fatal overdose once they are released. What can we do to help solve and help with that problem? To me, Jail Bridge was a really easy answer to that. Why not put things in place so that people, upon being released, even before they're released, know what resources they have? Well, it's not that easy to do, as we found out. But we're going to talk about how we were able to at least start this process, and then you'll hear from Deborah Troupe about how they've been able to do that in Clay County. I don't know if you can do the next slide or if I have the power to do that, but if not, we'll keep moving. We have 6 jail bridge programs in our network. You're pointing at something? Okay. Well, not my thing. Thank you. We have 6 jail bridge programs in the LSF network, and that is with Clay County Behavioral Health, with Epic, Meridian, SMA, Starting Point Behavioral Health, and 0 Hour Life that are funded through this initiative. We started out with 2, and we put it out for bid and encouraged our providers in our network to initiate these programs, just to encourage people to do that. And with that, people stood up to the challenge, and I also went around and talked to all of our providers too, to encourage them about why this was so important. You'll hear about Clay and how they've been able to do that. Next slide. So what did we find out? So we have about a year's worth of data from this past fiscal year. It really started in the second quarter, and you'll see those numbers started out fairly small, and then in the third quarter rose to 215 and stayed at that in the next quarter. So for the past year, 523 people came through the jail bridge program. That's a pretty large people in terms of being screened and then being referred to services. Next slide. I was actually pretty astounded at that number. That's a larger number of people going through the jail programs than our hospital bridge programs. Next slide. So how did that really break down? If these outcomes should really get your attention because it shows that it works. Out of 523 people that were screened at these jails, if I can't really see this, 386, I think it says, were referred. That's a high percentage. And look at the number of people that enrolled. So when you actually look at the number of people referred, based on the people enrolled, 82% of people that were referred to programs showed up. I never see outcomes like that. This is a very invested population. When they are referred to a program, they enroll. That tells me it works. Why does this work? Well, you have peers that are going into the jails and engaging with people who are incarcerated to say, there's hope. If you want to recover, there's ways to do that. And some of these jail programs, peers run groups. And also the conversation is about if you want to get help, if you want to get treatment, here are the providers that you can see. And if you don't want to go to a mental health provider, here are things in the community. These are conversations that aren't necessarily occurring in the systems that are set up in the individual jails. And these are individuals that have stood up and say, I'm here to help. If I can really share one thing that's most important to making a jail bridge program work, it's engaging the jail administration. I hear this time and time again. We want to do a jail bridge program, let's do it. Providers are excited about it. An RCO program, peers are excited about it, and it doesn't happen. So the desire is there, but it falls apart because the key stakeholders are not on board. Deborah will talk about that soon, about how many years it took to actually get this going in their system. And it really is a diligent process to build those relationships, to build the trust and get the buy-in from the jails so you can go in the first place. The other key takeaway, if you're thinking about doing a jail bridge program, is to remind you that MAT is not required for successful outcomes. One of the major barriers is getting access to MAT for individuals while they're incarcerated. Maggie talked about that earlier. Sometimes that's because there are contracted medical providers that don't allow it. Sometimes the jail wants to provide it, but there's not transportation. There are all sorts of roadblocks. Don't let that stop you. The important thing is having these conversations with people that are incarcerated, that there is hope, There's treatment, there are services in the community if they want to get better. The other interesting thing that we found out in this first year that surprised me, maybe didn't surprise Deb, one of the questions we ask in the screening is about diagnosis. Is this individual diagnosed with an opioid use disorder or other substance use disorder? Now, this is coming out of SOAR funding, right? So we actually found that a lower number of individuals were diagnosed with an opioid use disorder than another substance use disorder. Why do I think that's important? This shows me that a large number of people that are incarcerated have other issues other than opioids, and we're working with the funding stream, which covers opioids and stimulants. So we don't want to forget about the big picture with this, that some of the conversations that are happening are not just about treatment for opioids and stimulants, but other substances. Needs to be part of the conversation as well. The other key takeaway in the first year that we found is that the induction numbers were low. Getting people on to MAT is low. Why does that happen? We heard about that from Maggie. There are a lot of barriers to getting MAT into the jail system. If individuals are going to be released, why would you start them on that? You know, all these things that get in the way, or it may simply be the contracted, again, company that is working in the jail doesn't allow MAT. I also believe there's still a lot of stigma involved in creating that roadblock. Deborah will talk about how they were able to overcome that with their program by the ability to provide transportation outside, to bring people into their facility from the jail to get started on MAT. But I will tell you, that is the exception to the rule. There's a lot of roadblocks to transportation and getting that started. But if there is the willingness for transportation, that can be overcome to actually be transported to the provider and be started on, in this case, Vivitrol. Deborah will talk about the outcomes from her program with that. Maggie also touched on this. Narcan numbers are low. One of the questions that we ask out of the Jail Bridge program was the individual provided Narcan prior to discharge. Well, we already know this is a population at high risk, 12.7 times higher in terms of a fatal overdose within 2 weeks. Why wouldn't you give them Narcan, right? It seems so easy. Just hand them the Narcan. Not easy. We found out that these jail systems, well, that's not what we do. It's not in our part of our system of doing that. Who's going to pay for that? So something else that we thought would be kind of easy to do, we're still working on. And again, going back to the relationships with the jail administration, how can we overcome that? How can we get buprenorphine in the jail? So it's a long process, but I really think when there was the good communication and buy-in and the time is right, this can work very well. And another thing I'd like to stress too was that I think the reason that jail bridge programs we've been able to implement as many in our area is because of that. There's a paradigm shift right now where people that are working, first responders, I hear this time and again, we cannot arrest our way out of this problem. We are here to look at innovative ways to respond to addiction and substance use, and how can we do that? So they've opened their mind and their willingness to work with those of us in the recovery community to find innovative ways to make this happen for individuals that are incarcerated. Next slide. Okay, I'll turn this over to Deborah.
Hi, I'm Debbie Troupe, and I'm the manager for substance use disorders / jack of all trades at Clay Behavioral Health Center. I said in this slide that we started working on Jailbridge in 2019, and I don't think that's accurate. The more I thought about it, I think in my head it's like there was before the void and after the void. So I'm like, it had to be 2019 because COVID hadn't happened yet. So that's when it was. But it was probably closer to 2017. It took a little longer than I'm going to say. Somewhere around 2017, Clay County, which is right below Duval County in Jacksonville, we became part of the Project Saving Lives. That was a big initiative with Gateway Community Services in St. Vincent's, now Ascension St. Vincent's. And they brought it into Clay because they had built a St. Vincent's hospital in Clay County. So we got involved in that. We hired a care coordinator. We had peers in the emergency room not to give out medication, but to interact with anybody that came in with a substance use disorder. Or we said, anybody that you think needs someone to talk to them, if our peers or our care coordinators in the hospital, they'll talk to them. So it doesn't matter. Like mental health, substance abuse, we'll talk to anybody. Like we're bored. We've been here for 8 hours. It's cold because emergency rooms are freezing, and we'll be happy to talk to you. So, and that got me involved with the program unit supervisor at the Clay County Jail, who is the most, I've never seen anybody so invested in the jail population as Patty Atkinson is. She is 90 to nothing, and she will get services and programs for the inmates in the jail, to the point where you're like, okay, yeah, I'll do it, okay. She and I started talking. We want to get Vivitrol in the jail. How could we do that? We talked to the chief of detention at the time. He was like, yeah, that sounds good. Then we talked to the medical provider, and he was like, no, I'm not doing that. We were like, oh, okay. So then we got a new sheriff who believes very much that you cannot arrest your way out of opiate problems, and is all in on whatever community initiatives that the sheriff's department can be a part of. And then we got a new chief of detention, and he was like, yeah, I think we can do that. And then the transportation guy was like, I don't know, like I have to put him in chains and take him out of the, so we had that conversation. And then we talked to the medical director, and he was like, yes, 100%, we can do Vivitrol. And I literally just stared at him like, what? Did you say yes? So we got all of that put together, and then it was 2020. Okay, well, we'll just hold off on all of this. So here we are, 2020. Obviously, I'm still talking to the program unit supervisor. Nobody's in the jail. Nobody's getting in the jail. Well, people aren't getting in the jail. Not the way I was going to get in the jail. I didn't want to do that. People are not getting out of the jail. They're not getting sent to the state prison, so the jail's now overcrowded because they can't move them. There's like some sort of 15-day wait. You have to be in isolation. It was a mess. And our jail only holds, if you're in bigger counties, this will sound little, only like 480 people, I think. So it's a small facility that had a lot of people in it that couldn't go anywhere. And then people had COVID, and we were all there. It was a mess. And fortunately for me, one of my most brilliant hires of the last 5 years is I hired a part-time peer support specialist by the name of Paige. Paige is a little older. She has probably 20 years of AA recovery behind her, and she had been going into the jail and taking AA meetings for years. And I was like, oh, hey, Paige, what do you think about going into the jail and talking to people? And she was like, I would love to. I do it all the time. I go to AA and NA. I would do that. So we started out with Paige goes to the jail, even today, or not today, Wednesday. On Wednesdays, she teaches a substance abuse education class, and she does wellness recovery action plan. So she does a RAP program because she's a certified peer recovery specialist, and she does the substance abuse education. As we were talking about this, and now, like people are moving in and out of the jail, we're allowed back in. Paige is also even more brilliant of a hire, has a master's degree. She was a kindergarten teacher for years. Perfect. and she could do assessments. So when the jail agreed, we had a meeting, another meeting. We went down there. Chief of detention was like, sure, we can do this. The medical director was like, we can do Vivitrol. And the person that was in charge of transportation was like, yeah, I can send 2 officers and drive them up to your main office and they can get their injection and we'll drive them back. I must have dumb looks on my face in that jail multiple times because I was just like, transportation's okay? And they're like, yeah, and we'll do the blood work because Vivitrol requires blood work. And we'll do the blood work here and we'll fax you the results to the main center and the doctor will have them. And I thought I was in a dream. Like, I must be feverish. Like, I don't know what's happening. And I was like, really? So I have Paige that can do the assessment and the screening, and then you'll do the lab work, then you'll fax me the lab work, and then you'll bring them to me so we can get the injection. And they were like, sure, no problem. And I was like, oh, okay. So there we are. So, but understand, we're now in 2022, so it's taken a hot minute to get from here to there. But we've had really, really good success on the number of people, because let me just give you an idea about the program unit supervisor who now has AA and NA and Celebrate Recovery in the jail. All these are people, community-based organizations bringing into the jail active parenting, anger management, art, GED classes, life skills classes, mind, body, and soul class, music appreciation. I would love to sit in on that in the jail. But our substance abuse class that we're doing, I don't know, for those of you that work in corrections, Thinking for a Change, which is a remarkable program. Plus they have a vocational track for embroidery, engraving, and auto repair. And they're bringing in CDL licensing. She couldn't be here today because they're doing a job fair at the jail. I was like, really? And they have just put together a furlough program so people can go out and work and still, serve out their jail time. So when you talk about putting people together, you have to find your Patty Atkinson in your jail because she was just always like in front of the chief of detention, like, and that substance abuse, and he was like, oh my gosh, fine, we'll do it. She brings Bible studies in. I mean, almost anything. We've got to keep everybody that's in the jail motivated and busy. Busy people are good. So we've had 7 people screened for Vivitrol. They have to ask for Vivitrol, or Patty, who I don't know how you keep track of 480 inmates, but somehow she does. Or if you come in with a substance abuse diagnosis, opiates or alcohol, she will come to you and go, let's talk about Vivitrol. Like, this might be very helpful because the requirement is that they have to be within the last 30 days of their sentence, so they're going to be getting out of jail shortly. And we can get them at least 1 injection in before they go and get them set up for their second injection just at our clinic. And they've already are connected to Paige, who's the peer, so we already have all those things in place. If you're an unsentenced inmate, and there's quite a few of those in most jails, you can come to the substance abuse class, but we cannot get you on MAT at this point. The Clay County Jail is almost to buprenorphine. They're almost there, not quite. They've just recently started, if you come in on buprenorphine, they maintain you on buprenorphine. 6 months ago, you were just gonna go into withdrawal. And I'm like, somebody's gonna die. You're not gonna, it's not gonna be good. Now they do that. Their main objection has always been they didn't want to bring narcotics in the jail. So they didn't want that in there, but now that they're holding buprenorphine to medicate people, I think we're probably very, very close to the next step of getting buprenorphine. Also, Patty Atkinson, they took all the administrative staff out of our actual jail and moved them to another location, so they're refurbishing parts of the jail. So we're very, very close also to getting a jail-based treatment program. Once we do that, I think that's when we're going to be able to get our big push for buprenorphine, because we'll have somebody there with them. So that's going to be our next big thing. And the jail staff, the way this goes, if you want to come into our substance abuse group, you have to be screened by the jail staff. It's probably Patty. And they have a licensed mental health counselor who also is full-time there until last week when she had a baby. I'll show you back. But they screen them if they want to come to group. The nice thing is that the officers that are there leave the group alone unless something is going wrong. If you're disrespectful or difficult or give Paige a hard time, they will remove you from group and you won't be allowed to come back. But she doesn't, and literally Paige is this tall. Like, she is this tall. Like, they could like push her over, and they love her. Like, her ability as a peer support specialist is remarkable. I was saying, the best hire in the last 5 years, without a doubt. So this is our numbers for how many people are in group on the average. She averages probably 18 to 20 people in group every week. Now, you know, in a jail, you can say you want to go to a group, but you don't have to go. Nobody's going to make you go. They're not going to knock on your bed and say, you're supposed to be in group now. These are people that get up and walk to where they're going to be moved to the group room. So they want to do it. And we can always, every time I look at the monthly numbers, there's 18. One week there was like 12, and I was like, oh, pretty low. But I mean, and these are people that are wanting it and apparently are getting something out of it. Even some of the people that are, we've had one guy that was a little bit infamous in Clay County, but he had come in from the department for a trial, and he was in the county jail for about 5 or 6 months waiting to be retried, and he attended every substance abuse class while he was there. He just wanted, I think he wants to be better, but I don't know how that's going to turn out for him. So our numbers are good. She can do assessments. You know, I even use her. I'm like, because sometimes you'll be surprised to know that sometimes our substance abuse clients get arrested and they're in the jail. And I'll be like, oh, this is why so-and-so didn't come to group. Can you see if they'll let you talk to her and see how she's doing? Like, we can just check up on them. And depending on how things are flowing through the jail is very, very accommodating. I cannot stress how important it is to have a jail that wants to do things, that is on board with you can't arrest your way out of opiate disorders. They're very, very focused on recidivism. They don't want people to come back. They would like you to get out of jail and stay out of jail. And this is one of the many things they do, like the education. They're working on getting people's IDs before they get out of jail. You know, you can't do anything if you don't have an ID. Like, you don't have to have a driver's license, but you can't do anything without an ID. So they're working on getting that in place. So I think it's been pretty remarkable, even though we don't do MAT. Like, every time the MAT numbers come by, I'm like, 0, 0, 0. We also don't do Narcan. They're not there yet, but I think also that's coming. We're like, can you just put it in the lobby? Like, can we just like when you're packing out their clothes, can you just like throw a box in there with them, and just let them take it with you? And so that's a consideration. They're doing a good job of trying to integrate all of this as they integrate construction and all the other things. But I'm going to end this with a note that Patty sent me. It's what someone had written to her, and it says, "Dear Miss Patty, I'm not sure if you get this a lot, but I would like to thank you for the opportunity to be a part of the substance abuse class. It has not only helped me grasp the understanding on how substance abuse and alcoholism has had an effect on me and my choices, it also showed me that I truly am an addict, and I've been battling my substance and alcoholism for a very long time. I actually almost started to cry when I received my certificate, as it is a big accomplishment for me to acknowledge that I have a problem. I'm eager to show it to my family And if given the opportunity in the future, I would like to truly take steps towards sobriety and join the Vivitrol program, if I'm saying that right. Also, I'm going to admit myself to some mental health treatment so I can deal with my PTSD and major depression the correct way, not with alcohol and drugs. So again, I want to say thank you, and please thank Ms. Paige for all of her help and words of encouragement as well. And I was at a workshop earlier this week where you don't get this. In substance abuse, you don't even see people get well sometimes. You know, like, and they I'm not saying they don't. They just don't do it right here in front of me. You know, they may do it 6 months from now or a year from now, and they're good and they have a family, but you never see it. So it's really nice to have this validation that you are making a difference for people, that it's important, and they're actually learning something. And I think having these programs inside of the jail, we also have a hospital bridge program, so we're in the EDs. We have peers, probably, I think 6 days a week from 8 in the morning to 8 or 9 o'clock at night available for people that come in through the emergency department. And having that person with lived experience, this is not something that I can do. I'm a master's level clinician. I've been in the field 40 years. I know things. I know lots of things. I can tell you, you need to hear it from Paige. Like, Paige gets it. Like, she's been there, done that, all the things she's done, you know, and it's so important. So that would be my takeaway for Jailbridge. People that want, the jail staff has to want it. You have to be willing to, you know, like every time they're like, and you can't come today. And we're like, okay. Like, you have to be flexible. You have to be able to pivot. You have to be able to do what they need you to do. If they want me to talk to somebody, I'm like, sure, I'm on my way. I'll come down and do it. So you just have to, it's really a collaborative to make this kind of programming happening. So.
All right, thank you very much. Does anyone have any questions for Nancy or Deborah? Anyone? Right. Oh, there's one up front.
I had a question about the MAT in some of the jails. Is classification notified once they transition into the Department of Corrections to have some kind of withdrawal support if MAT is not available at that institution, or do they house them according to their level of OUD?
Yeah, I think that's a Department of Corrections
She left. Okay,
question.
sorry.
Yeah.
So feel free to reach out to Maggie. Her email's on the back of that, and she should be able to answer your question. So anybody else have a question for Nancy or Deborah before we move on? All right. Oh, we got one.
Hi, I'm Karen from Volusia Recovery Alliance. We actually do a jail program that's not a jail bridge, but we kind of walk alongside our partner SMA Healthcare. My question for you, though, is there plans to expand that? We also do RAP in there. We do smart recovery and a bridge between worlds, which is an alternative to art therapy. We're not completely funded for that, so I was just curious if there's any plans for expansion. Thanks.
Yes, you can submit the submission of interest SOI, and I'll talk to you afterwards about that. But there's expansion opportunity for SOAR.
All right, any more questions? Thank you both so much for your presentation. And again, the PowerPoint presentation that they just presented will be available online sometime later next week. So I'm going to go ahead and call up our next three speakers. This next presentation is on recovery supports. So we're going to call up Michael McKeogh with Oxford House, And again, Mr. Atkinson is home with that brand new baby girl, his first child. So we're going to have Lindsay fill in for him again. And we're also going to have Crystal Lilly, the State Opioid Response Project Director with the Department of Children and Families, to just give an overview of what recovery supports are. But we're going to start off the presentation. And again, we do have PowerPoints for all three of these presentations that will be available on the website. So we're going to start off with Michael.
Hello again. I'm Michael McKeogh, I'm person in long-term recovery. I work for Oxford House. I'm the regional manager for the state of Florida. First, to kind of describe what Oxford House is, I get a little bit in the history. So Oxford House was first started in 1975 by a group of men that were living in a halfway house in Silver Spring, Maryland. That halfway house, they were being informed, was shutting down. With the realization that they needed the structure and the accountability of that halfway house in order to maintain their sobriety, they devised a model to run it themselves. And so over the course of the next few months or however long it took them, they were able to come up with this system, this democratic process to run a recovery home themselves. And so they were able to save money on not having a house manager and a cook and a clinician and staff on site. And so the Oxford Houses are self-run, self-supporting recovery homes. Nationwide, can't really see this too well, but nationwide we have over 3,400, it's over 3,500 houses now, over 28,000 beds. It says 49 states, but it's actually 46 states and DC as well. And then we have houses in 5 countries. Our homes are available to men, women with children, and men with children, although we're working on getting some more men and children houses. In the state of Florida, we have 137 houses, actually 138 now, right at 1,268 beds, I believe. 28 women's houses, 23 women and children's houses. So a women and children's house is a women's house that also has the ability to have a woman with a child up to the age of around 12 or 13. And so that she can have her child living in the house with her. And that's not a problem. And then we also can do that with men's houses as well. And then we have 86 men's houses. Our kind of general progression throughout the state, we started our contract with DCF in 2019. We opened the first house in March. Throughout that first year, we had 30 houses. By December of 2020, 48 houses. And then bringing us to today, we had 138 houses. All right, so qualifications for membership. It's pretty bare bones. The only real thing that we're looking for is a willingness to work a program of recovery and not needing a medical withdrawal. And so somebody that is able to come to our setting and not have to go through detox. If they're needing a medical detox, they need to go do that first, whether it's for any kind of various substance, but that's not a medical facility. We don't provide any clinical services. It's not the setting for that. The large majority of people that come to Oxford House, about 80% are coming out of a inpatient setting, so your 30, 60, 90-day treatment program. About 10% are coming out of reentry. That's about 9 to 10%. We meet a lot of people. All of our staff and all of our members work recovery programs, and so we meet a lot of people in the fellowships, the AA, NA, Celebrate Recovery, Smart Recovery, the various things. And so a lot of times you just run into somebody and say, hey, I heard you need a place to go, and we have an Oxford House. Would you like to hear more about it? So again, they just need to have a willingness to work that program of recovery, ability to pay their equal share of expenses, It's not required that they are able to pay that expense as soon as they walk through the door, but as long as they have a good outlook of being able to obtain employment, get a job, and be able to start paying the houses, it's a pretty simple process. And then they have to be willing to adhere to the Oxford House model. Very simple stuff, willing to work a recovery program, attend the weekly house meeting, take their medications as prescribed, read the house manual, some easy stuff. So these are the members that do well in Oxford House. It's not a list of everybody, but these are the kind of ones that kind of stick out that you might see more often. Opioid use history, co-occurring. So with both of those, really the accountability to take medication as prescribed, it's huge. When you're dealing with somebody that has been self-medicating for years and now they've gotten out of treatment and they've come to a recovery home, just that accountability, that peer support in place to say, hey, you need to take this as your doctor has prescribed it, and as long as you do that, you can continue living here. And it's essential for you to continue living here. And so we see a lot of good results with not only people on medically assisted treatment, but also people that are dealing with some kind of co-occurring issue that might be on psychotropic medications. Veterans do excellent in Oxford House. Again, I think that's around the 10% mark of people that are veterans living in Oxford House. Drug court participants, a lot of the things that we require out of our residents align directly with what is required out of drug court participants, and so it's a pretty easy living solution for them. Reentry, Oxford House, now with 138 houses, over 1,200 beds, is one of the largest reentry housing providers in the state. They do have to have substance abuse as an issue, but they're welcome to come to an Oxford House directly out of incarceration. Chronic reoccurrence. So this is a big one, especially in Oxford House. So a person that has been in and out of treatment, they have been in and out of halfway houses, and they've heard everything that the counselors have to hear. They can tell you what the counselors have to say better than the counselors themselves. They might have this kind of resentment of authority. They might have this chip on their shoulder. But when they move into an Oxford House, it's peer run. And so now you have a group of individuals, a group of your peers asking you to do things, asking you to participate in a recovery program instead of a house manager or a program director telling you what to do. And so you get to see a pretty large perspective change and a lot of people that are much more willing to participate in what we have going on. All right. Benefits, members receive 24/7 peer support, so you live with a group of peers, a group of people in recovery. You can talk to them at any point in the day. So if you're going through whatever, if your mom is sick or your girlfriend broke up with you, or you're thinking about using, you can just go and knock on your neighbor's door. You can sit down on the couch and talk to your roommate, and you can talk it out, and you have that there all the time. And so in difference to a person that is working a recovery program and they're actively going to meetings and they have a sponsor, generally speaking, you only get to do that 1, maybe 2 hours a day. Here you get to do it all day long. Responsibility, accountability. So we do expect things out of people that live in Oxford House. We expect them to participate in our model, that self-run, self-supporting democratic procedure that was started back in 1975. And so we expect them to take on some responsibility, and the other members are going to hold them accountable to that. But through that process, you get learn a lot of cool things. You get to learn how to have difficult conversations. You get to learn how to balance a checkbook. You get to learn how to just take care of yourself. I know that I needed to learn those things when I first moved into an Oxford house, and a lot of people do. And I think the biggest thing that I've learned through my tenure in living with an Oxford house is really how to have those difficult conversations. How I'm able to sit down with my wife or sit down with a family member now and able to put it all on the table and do it in a loving, compassionate way. Before, in my active addiction, I was never able to have those conversations. I was never able to just get it all out there. And my solution to all those emotions that I was feeling was to just go and use. And so now I'm in a safer environment, a recovery-centered environment, that I'm able to learn how to do that properly. You have safety in your recovery, stability. We want good houses and good neighborhoods, and so we want people to feel this ownership and this pride in Oxford House. And so at the end of the day, we want them to feel safe that I'm going home to my Oxford house. I'm going home to this rock, this place that I can just feel comfortable in my own skin and just really grow in my recovery. And we offer them a chance of success and that self-efficacy. These are all the current locations that we're in. There's a couple more on there. I think Sarasota might be missing and a couple others. If you go to our vacancy website, it's oxfordvacancies.com. It lists all of the houses in the country. It's a really cool website. It will actually list the vacancies that each house has. And so if somebody's looking to get into a house in, say, Panama City, they can pull that up, pull up Bay County, get a direct contact number to that house, call the house, set up an interview, and then pretty much move in from there if they are accepted. This is a list of our outreach contacts. If you want to take a picture of it, you can. We also have some brochures down there. You just reach out to our staff. They're all amazing people that are very passionate about Oxford House. Oxford House only hires from within, so all of these individuals have lived in Oxford House, moved into an Oxford House, whether it was out of treatment, out of jail, out of outpatient services, whatever have you, and now they work for Oxford House and they get to share what Oxford House is with the community and the people in their area. Something that we're very proud of within Oxford House is we're on the National Registry of Evidence-Based Programs and Practices. We have had many studies done on Oxford House, and over the numerous years Oxford House has been around. And through that, we've been able to get the recognition that Oxford House deserves because we're helping a tremendous amount of people. And so Oxford House community-based model for recovery, offers peer support, mutual aid is emphasized, substance-free democratic home for individuals, members provide social support, accountability, and mentoring, evaluated in studies, effective in reducing substance use, improves employment, income, and social functioning. The registry recognizes Oxford House as evidence-based practice. Becoming a member, so I was talking about the vacancy website. So you can either call one of the staff members, have your client call one of the staff members. You can go on the vacancy website. You can fill out the online application. But really all it is setting up an interview, calling when it's time for the interview. It takes about 10 to 15 minutes, or coming in person, whatever they prefer. If they want to come see the house, we're completely fine with that. Doing the interview, the very, very, very large majority of people that interview for Oxford House are accepted. Again, it's done on a democratic basis, so they have to receive an 80% vote by the existing membership. Once they are accepted, they're able to move in immediately. And so it's a very simple procedure. And again, they don't have to have any money from the door. They just have to have a good, solid outlook of being able to obtain employment in a timely fashion. And there's help out there with that initial assistance with RCOs and different providers throughout the state. DCF has been really great in providing transitional vouchers to different organizations which can be sent to an Oxford House to help that individual with their initial stay. So that is it.
Thank you, Michael. Does anyone Does anyone have any questions for him? Oh, we got some right here.
Yes.
Really quick, I may have missed it, but I saw that you said women and children home is available. Is there a father and children's home? And can they reunify there?
What was the last part of that question?
Are they able to reunify in the home if they have a dependency case?
Yes, so currently in the state of Florida, we only have women in children's houses. We have had 2 men in children's houses in the past, but we are definitely working hard on finding more men and children locations. It's definitely something that we are trying to do. And we've had quite a few reunification cases that have been successful within Oxford House. Some amazing stories of people getting reunited with their kids.
Hi, so a question about capacity. What does your capacity look like at Oxford House? And if you meet that capacity and someone comes and they're unable to shelter at your place, is there a referral program to a different place? How would that process look?
So if the house is full, they're doing the interview for the individual. They would put them on a waiting list. If they're not full, obviously they can be accepted and move right in. Generally speaking, in the majority of areas where we have houses currently, we're able to say, all right, we're going to put you on a waiting list, but you can interview at this house over here. And then just the transitional nature of Oxford houses. I mean, there's usually an opening that pops up every few days or so, depending on the area. And we do know that there are houses and areas that stay very full for a long period of time, and we're definitely working on opening more houses in those areas. But yeah, to answer the last part of your question, we will absolutely refer to other organizations, work with other sober living houses in the area, and try to get them a good solution for their next step.
Okay, we have another question.
About how long can a person stay there once they have been accepted?
Excellent question. So in Oxford House, you can stay as long as you wish. It is completely up to you. We will never ask anybody to leave in order to create space for another individual. We'll literally just go open another house. And so we have people living in our contract's 4.5 years old. We have some individuals living in Oxford House for over 2 years now. And that's fine, and that's what is comfortable for them. The average length of stay is right at 11 months.
Okay, we have another question over here.
Hello, I have one question. So I know you said that you accept people as long as they have like a prospect for employment. Do you also have like a process in place to help people find employment once they're in?
Yeah, so to kind of get into what Oxford House's service structure looks like, we develop chapters, and these chapters are comprised of all the houses in a certain area, and they have a board basically of our membership, and they have a subcommittee called a Housing Services Subcommittee, and they develop all kind of resources, and they help with job placement and food and clothes and all the things that are necessary to get somebody transitioned comfortably into an Oxford House. So yes.
Yeah, I have a question. Is the program, is it in phase? Do they go through a period where they do nothing, then they're able to work? How does that work?
There's no phases to Oxford House. There are voluntary positions and voted in positions within our service structure, within the houses. And so somebody might move in, they might not be the house president the first week, but they might get voted in a couple months. But no, they're not required to delay working at all. They can go out and work immediately and do all the things that a normal human being would do. It's just, we're there to hold them accountable, to work a program of recovery, and to provide that support for them to do that successfully.
Mine isn't so much a question as a comment. I am with the Lee County Drug Court, Mental Health Court, Veterans Treatment Court. Tyler is my representative. So I just wanted to speak on the fact that he's always phenomenal when we need someone that needs a bed. One of our graduates still lives there, still comes and speaks at our public safety committees. super involved in the community. So just Oxford House and everything that Oxford House does in Lee County is phenomenal.
Well, thank you. Yes.
Oh, hi. I was looking on the directory on the website and noticed we didn't have any Oxford houses in our county, which is Nassau. I was just curious, what is the process for opening additional houses? Like, how does that happen?
So get in touch with one of those outreach coordinators. You can get one of our brochures. You can come over here and meet Chandra and Tyler, and we can definitely start talking about it. So even though we're 4.5 years in, we're only 4.5 years in. We're just getting started. We want to open many, many more houses in the state of Florida and continue providing housing throughout the state.
Oh, we got another question. We got one over there too. Hang on.
Hi, good afternoon. We are from Lee County, Fort Myers, Florida. See that you have houses in Cape Coral and Fort Myers. We're currently in the process of opening an IOP. If you have a client that wants housing at one of your houses and they're on disability and not able to work, is it required that they take part of that money for like weekly rent, or do you have them volunteer to give back to the community? What is your protocol?
Yeah, so they would need to pay the equal expense in the house, and so that's a requirement for all members in Oxford House. So whatever that equal expense is, I believe the majority of houses down there are $175 per week. So as long as they're able to meet that, they can live in the house. And then as far as the work, there's not a work requirement. They are required to get out of the house on a consistent basis, so they're not isolating, so they're not becoming depressed, because that leads to all kind of bad things for people in recovery. And so, yeah, usually a person that is on SSI or they're retired, we'd want them to go out and do some kind of volunteer work, get out in the community, and really kind of develop themselves.
All right, we have one more question right here.
Hi, Victoria from New Season. I just want to thank you guys, first of all, for what you do. We're nationwide as well, and we work really closely with a lot of your guys' houses. We're a MAP program that provides methadone, so it's really hard to find housing for our patients sometimes, and you guys have been great. We really appreciate how updated you guys keep your database too. It's phenomenal. Thank you guys so much for everything you guys do. But because we are nationally, nationwide, it's been a little bit difficult for us to work with you guys on like a national status. So do you have any recommendation for that? Anybody that maybe we can get in contact with to better connect in all the different areas we're both in?
Yeah, absolutely. Come and talk to us afterwards. Also, we're hosting the Oxford House World Convention in 2024 in Orlando, so if you want to come up for that, it's going to be really cool. But yeah, come and talk to us. We'll get you connected.
All right. Thank you, Michael.
Oh.
Again, his presentation will be on the website late next week. His contact information is also in your brochure. But right now, we're going to go ahead and let Lindsay speak on the Recovery Epicenter Foundation.
Hi again, everyone. I am filling in for Will, so this is the second time I've seen this presentation because he spruced it up a little. But when I got into recovery, I had no idea about how many acronyms are in this. So like when he started saying RCO, I was like, what are you even talking about? But a recovery community organization is, again, like that resource hub. You know, we might know the treatment centers in our area. We might know some AA or NA meetings in the area, but an RCO is generally focused on its actual community. So for us, we work in Tampa Bay, and folks in recovery, you know, I don't know, there's websites, there's social media, we're out on that. But honestly, in our world here, it's word of mouth. That's how people find us. So someone needs help, someone knows, you know, hey, call this place, and that's where we step in. So we do everything from peer support services. Housing is a huge need for people in recovery. So we have to have community partners like Michael's Oxford Houses in order to get people a safe and supportive environment to live in. Another acronym I heard was RC, Lindsay, RC, Recovery Capital. And I was like, what are you talking about? So that's Recovery Resources. It's hard to stay in recovery if you don't have a place to sleep at night and you're terrified of the guy in the bush next door to you, you know? It's hard to get to a meeting if you don't have transportation. It's hard to think about recovery when you're hungry and starving and don't know your next meal's coming. It's hard to think, you know, if you don't have a social support network. So these are the things that we concentrate on with the folks we work with to try to get them more resources than they had before they came to Recovery Epicenter. So with that said, I'm going to go through the history. You know, we started a grassroots effort. So this was our founder, some people in recovery, and some people he knew in the recovery industry. Recovery Epicenter did some events, and then we got a contract from our managing entity, Central Florida, and we started recovery coaching. And that was working directly one-on-one with people. We had folks in halfway houses. We had folks that were referred to us by meeting clubs. Sponsors would send people our way. And all these people were looking for, again, was taking that next step, or an ear, you know. They just needed an ear to listen. They didn't need to be told what to do. They just needed someone to listen. So we've grown from that into a whole bunch of different activities. One of them is our homeless outreach. We do that in Pasco and Pinellas County. We are blessed to get a lot of donations from folks within the community to help us disperse this out. It became, you know, it started with Narcan. We wanted to make sure Narcan was available in the homeless camps behind this, you know, 7-Eleven. We also provide food, a little bit of clothing, hygiene, sorry about that, and hygiene needs. So socks are a big necessity. But we also want to sit down and have conversations with folks that are interested. So not everyone is, we recognize that, but our focus is on recovery from substance uses. So mental health comes right in with that too. If we don't know, that's okay. We're going to connect you with someone that does know. And that's the key here too. We're not everything to everyone. Narcan was a biggie for us this year especially. We had, trying to think of this adorable young lady that knocked on our office door and came in and said that she was going on, I don't even remember the band, that she was going to follow this band around the country, and she saw us on the news and wanted a bunch of Narcan so that she could distribute that along her little road trip. And I was like, okay, sure, come on in. But, you know, spring break is a hot spot. We're right in Clearwater, so we've got the beaches there. And probably 3 or 4 years ago, when we went out to the local motels and hotels to hand out Narcan, we got a lot of no's. Hey, you know, that's not, we don't handle, that's a liability. We let the emergency department take care of that. We just make the phone call. Well, times, thank God, have changed. You know, that, again, the stigma is people are listening to us. We're listening to the recovery message. So we are noticing a lot of people reaching out for Narcan. And all the events that we go to, again, we got a lot of response. My biggest obstacle for me is my mom and dad. If I can convince my mom and dad of these recovery concepts, you know, they're like Nancy Reagan. They're like, just don't do it, Lindsay. Just don't do drugs. What are you thinking? So if I can convince them that Narcan needs to be in their household, you know, you never know if the neighbor mom or the cleaning lady that comes in, you never know. I know we're doing pretty well as far as getting that message out. Training opportunities. It is imperative that we participate and host trainings, both for our staff internally, to make sure that, again, we're not just these, you know, honky AANA folks, you know, we're grassroots, baby. I wore jeans today. We're professionals too. And again, we want to have all the knowledge and have all of our staff trained, and we want to, again, get that opportunity out to our peers in the recovery community. So we work with folks, we work very closely with NAMI, who provides a lot of peer support training. A bunch of Central Florida's got a bunch of online training for peers, and we look for our staff members to get peer certified within 1 year of hire. Collegiate recovery programs. We are on the campus of St. Pete College. We have been given an opportunity to get a couple interns about each semester that are in their addiction studies course. And sometimes I'm like, yeah, here's the filing cabinet, good luck. But most of the time, they love working with people. They love getting into this and seeing, where they can make a difference. So we try to give them a variety of different tasks. And we heard over and over that they needed someone. They needed to peer on campus. Now, in one of those programs, that's just kind of a communal campus. So there aren't, people living there. But peers are coming into the offices we have on site there, asking questions, getting information. And then we started working with the Eckerd College, that was the name of it. And again, they are a residential, housing college there, so we knew that'd be a great fit for them. But we're getting a lot of interest, not just from the students, but also faculty members. We always talk about how this disease does not discriminate. So, you think you're targeting a specific, like, all right, spring break, let's get to this. Well, it's the business owners we found out that, hey, my cousin this, or so it's really important to us to keep an open mind as we're doing our events. And the big thing is, in our community, we have to listen to the needs of our specific region. We do work with the Oxford Home as far as housing. We do work with other RCOs for their specialties that they provide. So this is a big network throughout Florida. Our newest adventure that opened here is the Catcher's Mitt. And it's a weird name, but it was meant to catch the folks that fall in between the cracks. A lot of the sober homes, we found that when someone relapsed, they'd get kicked out, and if they didn't meet a medical detox at the hospital would send them home. So they'd end up sleeping on someone's couch, maybe just sleeping out on the streets for the night, but they didn't have a safe place. So again, pretty hard to get activated back into recovery if you don't have a place to live, you have no one to talk to, and again, that shame and guilt of the disease comes over you. So this is a peer respite home. This is run by other people in recovery, a safe place, open 24/7, so no matter what time of the day you need it, you've got a place to come in and get plugged right back into recovery, not even miss a heartbeat. It's all voluntary, though. We can't make you stay, but you got people there that you can talk to and start getting those resources again. And what we need to do from a peer perspective here is find the best solution for them to when they transition out of the respite home. So sometimes that's a sober living program or a recovery residence. Sometimes they need a higher level of care than they were receiving, so we'll transition that. And right now we've got about an 87% success rate of getting people transitioned into a safe environment in their next step. So we're doing pretty well. Recovery roundtables. This is, again, our venue that we use to talk to folks in the community and find out what the needs of Tampa Bay are. So we ask stakeholders, other network providers, just about anyone that has something to contribute to the recovery world to come, talk, get it out. It's an open forum, and then take action. Who's going to do what and when are they going to do it by? So we're pretty active in our communities on these roundtables and making sure that, again, we try to invite the people that are going to make a difference. Community events, again, I'm a peer. I'm a person with lived experience. So if sobriety sucked more than, when I was, there's no way I'd stay sober. It had to be better. So I didn't know how I would live my life, going to a wedding and not drinking. I didn't know how I would do my normal life activities without substance, because that's what I knew for, a decade and a half. So when I started hearing things like they're doing a sober softball, I was like, lame, that sounds lame. But then they had a sober yoga thing, and I was like, okay, maybe I'll try that. And then they had a movie night, and then they had, a whole bunch of activities where I'm like, okay, well, I can't pass this up. And I met fantastic people, got plugged in again, expanded my network in recovery. So I think that's important too, to recognize too, that there's just, life goes on and there's fun stuff to do. So the next steps here is we had developed a software program. Again, I'm going to use my personal experience on this. My 12-step program gives me a coin for little intervals of, abstinence. So when I was getting traction in AA, I couldn't wait for that 1 month coin. And then they gave me another one for 3 months. And before you know it, when I was getting my 6 and 9 months sobriety, I was going to like 50 meetings just to collect like a bag of chips. And I'm like, look at me, I'm doing it. And I needed that dopamine and I needed that pat on the back. This software program, again, is reinforcing behavioral modification. So, hey, I went to a meeting today, bing, you check in and you coin out and you actually get some sort of recovery currency. And that recovery currency might develop into a coffee coupon or, a free bowling round. But again, it's to motivate people through making good choices in their recovery. The other thing that we talk about over and over too, peer support. We have a fantastic team right now, but there's not enough of us on the street. So training helps, food, but the reality is we need to get people stabilized too. So housing is a big problem in Tampa Bay. I don't even know what the rate is, but my rent went up 22% in a year. And so it was hard even on me. So folks, again, that are looking to try to just get stabilized in life, it's pretty hard when we don't have a place that they can afford to stay in. So we are looking for housing vouchers in our area. Is this still going? No! Is this still on? All right. Housing vouchers. Maslow's basic needs here, shelter, things like that are really important to just get going in traction. And I'm not sure what the other one was, but probably should have, printed out a PDF before I left. We'll see if it comes up. Harm reduction, thank you. Harm reduction. Again, someone was paying attention. But I think until it comes up, I'm just going to say thank you for this opportunity. This conference means a lot to me, again, on a personal level, because this makes me think that we are all part of the conversation here. We all are stakeholders, and we all can make a difference. So thank you.
I think we have a question for you.
You mentioned contingency management software. The last panel that I went to for the other one next door was about contingency management and software. Is this one that you're using, one that exists, or developing one?
It is in development right now. So again, I actually don't have all the details because I had to sign some paperwork on it too. But it is meant to, again, track these positive actions that people take in recovery and give them a reward for it. So, yep.
There's an excellent presentation by the Dr. Gastfried. If you ever need to convince anyone of it, he's got it great.
That's the man? Okay, thank you.
All right, do we have any other questions? Oh, Eve's got a couple on the other side of the room. And we'll hopefully get the next presentation up in the meantime.
So mine is not a question. I want to add an activity to your calendar.
Okay.
We do a Soberlicious New Year's Eve party on New Year's Eve with a fantastic mocktail kind of, get up, everything. We dance, we sing. It's so much fun.
That's awesome.
So I will send you something if you want to circulate it
I'd love
for
to.
next year.
That sounds
And
great.
yes, and it is on New Year's.
Yep.
I get the question, when are you doing the event? I'm like, New Year's? Because it's a New Year's Eve party, and that's when it's meant to be.
Yep.
So I just wanted to share that.
Thank you.
So my question surrounds your respite center. Is there any type of criteria you're using for reoccurring individuals you see all the time?
We allow anyone back in the home, we'll say that. Again, this isn't a typical sober living type housing. We want you to come in, we want you to stay safe. We have a capacity though. So our house holds a lot more than we actually do because we have staff there that needs to meet the needs of these folks. So we found that one peer can service about 10 participants and get them to that next step a lot quicker. So again, if you use in the house, if you have drugs on the house, like we're going to discharge you. It's not safe for the rest of them, but you don't have to come in clean. And again, as long as you're working toward the next step in recovery, that's what we're looking for. Someone had asked earlier too, if someone needed to get into an Oxford house and it was full. We use the respite a lot for that. People coming out of incarceration that the sober home might be full right now, so they just need a couple, maybe a week to stay in a safe place before they transition into there. So yeah, thank you.
Thank you very much, Lindsay. Crystal is up next, but you have, yes.
Not going to miss that opportunity. Brevard Recovery Fest, celebrating National Recovery Month, September 9th. Wickham Park, Brevard County, Melbourne, Florida. Come on out, free family fun day. Everything is included for, did I say free? Yeah.
All right, we'll see what Heather can gather her back up for her presentation so that she can at least speak to you for a little bit, as I think we're having some issues with the electrical over with the equipment. So I'm going to go ahead and let Crystal Lilly from the Department of Children and Families, she's the State Opioid Project Director. So the slides, the presentation that she should be able to present. Oh, looks like we got it. So as soon as we can get things up and rolling, but Crystal, if you want to go ahead and start, and we'll get your slides up.
Hello. Thank you. My name is Crystal Lilly, and I'm the State Opioid Response Grant Project Director for the Department of Children and Family. And I am going to talk to you briefly about what a recovery support is. And then I guess I need the clicker, don't I, so I can keep going here? No? Thank you. Some examples of recovery support, dimensions of recovery, and then recovery housing. We've already heard the wonderful supports that Oxford House and Epicenter are providing. So thank you both for that presentation and sharing all the great work that you're doing. What is a recovery support? By SAMHSA's definition, it helps people enter into and navigate systems of care, removing barriers to recovery so they can stay connected and live in their communities. Essentially, everything they need to stay well and live the life they want to live. Supports are implemented before treatment, during treatment, after, or even without, depending on where a person is in their own recovery journey. Services may be delivered through a peer or other professionals, but it really just depends on where that person is, meeting them where they are, and what they need at that time. So recovery supports, it says peer supports, but it should say recovery supports, sorry about that. These are just some examples of what that could look like. There's many more. This is not anything to do with covered services, but just what a recovery support can be. It can be peer support or employment support. Recovery schools, we have a few of those in Florida that have popped up that are as a wonderful resource for our youth. Recovery coaching, workshops such as RAP. It's been great to hear that that is going on across the Florida. I'm an advanced level facilitator for another month before my certification runs out. And I love that that is still moving across Florida because it's a great tool. Dental care. That could be a barrier. Anything that's a barrier to preventing someone from maintaining or getting where they want to be in their recovery can be something that is put in place. It's one of the recovery supports. Recovery residents. Social connections. We all need to feel part of something. Any of the providers out here have heard about the Deborah? I know it's a sore spot right now. But this is where the data's coming from, so I just wanted to let you guys know that's where we're getting this. And this is for the fiscal year 22-23. Or 21-20, everything else is for that, but this is because of the Deborah. We all know January 23, it went dark, right? So for fiscal year 21-22, 10,570 individuals received recovery support. For this next fiscal year, up until just January, those numbers were rising. So we are connecting people to more recovery supports. These are just some examples: aftercare, recovery support, which is peer support, employment support, where you can see just where those numbers are coming from. That's not the total by any means, but just some of the highlights of where some of the larger numbers were. Education, housing support, a lot of education, people wanting more information. The 4 dimensions of recovery, the reason this is on here is because there are those 4 components that make up a person's life that they need to have in order to be well, have all their needs met. Health, having access to health care, being able to make well-educated decisions with the knowledge to make choices about healthy decisions and know what is out there for the resources. A home, having a safe and stable home. And Jennifer spoke earlier that that's not something everyone has access to. A purpose, having a purpose in life, things that are important to them. And community, being part of a community. But home, that home piece is what we're gonna highlight, because that is such an important component that people do have a safe place to live. Recovery residence. The statute defines a residence as a dwelling for persons entering to provide a peer-supported, alcohol-free living environment. The Florida Association of Recovery Residents administers that program. And if the home is going to be certified, they do have a certification process at each one of those locations. Again, they're certified through FAR. Population is someone that's diagnosed with a substance use disorder. They have access to community treatment and supports. Department funding restricts homes that are not registered or certified unless it is an Oxford House or a provider that is contracted with a managing entity. There are different levels of support for recovery residencies. That first one, the peer run, it's democratically run. There's no paid staff there. I think of that as the way Michael was describing Oxford House. There's a manual instead of policies, drug screenings. And then the monitored, that there is a paid staff there, sort of a manager of the house that's taking care, monitoring everything that's going on. There's peer-run groups. There's treatment outside of the home. It's usually in a single family home, as is the peer run. Level 3 is supervised. Now, with this one, there's still no services, clinical services inside the home, but there are peer services, independent living skills and such. And it's a little bit more structured with the hierarchy. And then 4, the service provider. These are licensed, there's treatment services there, there's usually a step-down program, more intensive treatment involved. There's treatment in-house, everything is done in-house. And these are all things that, the reason we're talking about these is these are things that SOAR can pay for so that people can have a safe place to get through their recovery. This is just a map of all levels 1 through 4. And on the little, the pin, you can see how many are in that county. The pin is not dropped anywhere in the county that says this is the exact location. It's just the county. All right, and that's all I have on recovery supports. Thank you. I think I'm...
Thank you, Crystal. Does anyone have any questions for her at this time? Oh, we have one up front.
Thank you. So if you're not FAR certified and you're not an Oxford House, how do you get the contract with the managing entity or DCF to have a house that you can have referrals? It has to be FAR certified?
That would be a conversation with your managing entity, whatever their process is.
Thank you.
All right. Any other questions?
Yes, back here.
Oh.
My question is specifically, I represent Tri-County Human Services in Polk County. We only have one certified residence. Is there any funding available to help community partners set up these certified residences?
Through SOAR, not at this time to actually start up, but that doesn't mean that funding's not out there. That is, again, another question for your managing entity to see if they have any funds available, but I know that our grant is not funding that at this time.
Could I get a clarification on your GIPRA numbers? Did you get that from the data that we're putting in?
It came from WITS.
So that is part of, because like we do 1 million GIPRAs, and I'm like, I never see, like, what's the data? And there it was.
That's it. That's the recovery supports.
Okay, thank you. That's very helpful.
All right. Do we have any other questions? If not, I'm going to ask Crystal to remain on the stage, and let's thank Lindsay and Michael one more time. All right, so Crystal, take it away for the last portion.
All right, yes. This is the presentation that's the fiscal year 22-23. I knew it was there. So we are gonna just go over the accomplishments. We've done some great work. You guys have done some great work. Thank you for all of the work that you have done in this room, because without you, none of this would have been possible. So thank you very much. I'm going to go over the goals of our SOAR 3 grant, bridge program, training and technical assistance, behavioral health consultants, recovery-oriented quality improvement specialist, Oxford House, which we've heard from him, but we're just going to talk about a little bit of data. The recovery community organizations, treatment and recovery supports and prevention, and that will close us out. So these are the goals of our SOAR 3 grant. This is the third SOAR grant that the state has been awarded through SAMHSA. Number one, we want to reduce the numbers and rates of opioid-caused deaths, prevent opioid and stimulant misuse, and increase access to the most effective treatment and recovery supports for opioid and stimulant use disorders. Our bridge program has expanded. We have increased to 48 sites, so different hospital locations for our hospital bridge program. And we have increased to 9 jail bridge programs that are SOAR funded, and this is based on the data that we receive each month. Through the hospital bridge, we've had 9,659 individuals screened that have come through the emergency department. 71% of those were referred for services. So they were referred out to our treatment providers. Inductions are low. We've heard that across the board through all of the presentations. We are working to increase those numbers. Our jail bridge screened 684 last fiscal year, with 72% referred for services. And I do want to just say that both bridge programs are to increase access to low barrier, FDA-approved medication for people that have an opioid use disorder and need treatment. We want to eliminate those barriers and increase that access so that they can start their journey while they're going through an emergency department or passing through a jail setting. This is a map that will illustrate the county locations of the hospital bridge and jail bridge programs. The orange icon, hospital, and the green star for the jail bridge. If you can see the hospitals, the number represents how many are in that county. So we have a hospital bridge program in 24 of the counties, with 9 counties for SOAR identified as for jail bridge. Our treatment and technical assistance training that we are working with FADA to provide medication-assisted treatment training for probation officers and correction staff. They will be assisting the Department of Corrections with their pilot program, which is very exciting. We also contract with them to coordinate this summit every year, and with the peer prescriber mentors. And the peer prescriber mentors are specially trained physicians that have experience treating individuals with opioid use disorder or stimulant use disorder and medication-assisted treatment. And they serve as mentors to other physicians that are interested in expanding a bridge program or starting a bridge program. They're available to train, educate, consult in real time if needed, to answer any questions that may come up as a new hospital location or jail location is working to develop a bridge program. And they are accessed through FADA. So Diana is actually the one to reach out to if anyone wants to request information or set up a meeting with one of the mentors to discuss next steps, or even just have a question if there's barriers you're trying to overcome. They're just a great resource to have. Our behavioral health consultants are licensed mental health counselors who work to support and educate child protective investigators or dependency case managers to identify behavioral health disorders, diagnoses, and support families and keep them engaged. They also help with learning best practices for treatment and engagement, including medication-assisted treatment. During the last fiscal year, they assisted 11,160 child protective investigators. And of those cases, 8,306 had children 5 and under. So they're working with a lot of families and a lot of child protective investigators to ensure that families are getting the supports they need with individuals that understand what those needs are able to identify them. SOAR, and this is only SOAR, there are other funding streams that do pay for behavioral health consultants. But we pay for 30 in the state with SOAR funds. There's 4 in the Northwest region, 7 in the Northeast region, 5 in Central, 8 over in Suncoast, 4 in the Southeast region, and then 2 in the Southern region. The 2 in the Southern region are the only 2 that are actually contracted out through the managing entity. The others are all housed at the regional offices. Our recovery-oriented quality improvement specialist, ROKIs for short, are peers with substance use lived experience. There's 1 in each region. They are there to be the liaison between providers and managing entities or RCOs, provide education and training to peers in the community, work to increase peers in the workforce. They may do Wellness Recovery Action Plan training, ROSC, introducing the providers or communities to the recovery-oriented system of care. They also conduct and document quality assurance visits with providers to make sure they're following the principles of ROSC. Through technical assistance to managing entities, service providers, and peers, there were 1,263 instances of technical assistance provided last year at request. And also 48 trainings. The trainings were ROSC, Wellness Recovery Action Plan, peer professional development trainings, and whole health. So those were some of the opportunities that they trained last year. And their trainings are open to the public, but generally our peers, but also other providers or community members. Oxford House, Michael has the latest data from Oxford House because he has the inside. So mine's a little old. There's 2 more on his list that must have come on this next month. So the last fiscal year, they established 37. They're doing phenomenal work. At this time, there were 25 counties. It may be expanded now when I see where the other 2 are. But this map shows how many per county there are. So they are really spreading, I think, quickly, considering it has only been 4 years. And we, through SOAR, our fiscal year, which the grant is a little bit different than the state, they do 44 for that cycle, which they're doing fantastic work. I visited a couple of their homes, and they are, and met some of the residents, and they're very organized, clean. It feels like home. It feels like you're walking into a home. I really enjoyed it. SOAR also funds recovery community organizations. This is a passion of mine because I came from a peer-run organization where I worked for many years, so I understand the value of peer voice and the value of having a peer at the table through services. So they're peer-run organizations providing recovery support services, training, advocacy, outreach. There's so many things that our RCOs do. Faces and Voices of Recovery provide that technical assistance and training as we build capacity. So they're a national organization that has come in to help us build our RCOs across the state, helping us expand and develop new organizations. This is another map just showing where our RCOs are. Some serve multiple counties, like Epicenter serves multiple counties, so you'll see the orange in a couple of counties because just a service area. So the orange star just shows the service areas that we have available, and over to the right you can see the RCOs themselves, the names of the RCOs that we currently have. treatment recovery supports. This data came from FASMS. That may be a tricky source subject too. I'm not sure about that one. But FASMS data, all of our recovery and treatment supports, or treatment and recovery supports, for SOAR 2, the no-cost extension. So we've got 2 grants going side by side right now. SOAR 2's closing out. SOAR 3 just began. So for SOAR 2, 14,751 individuals received treatment or recovery supports, and 2,818 through SOAR 3. So that's a lot of people that are getting the treatment and recovery supports that they need. FADA also has a contract with SOAR, or under SOAR for Vivitrol. So they've served 930 individuals with Vivitrol through the last fiscal year. Prevention. Universal, indirect, and direct are media impressions. So these are the numbers that I illustrate how many individuals were touched through media impression or through prevention programs. So there's an approved list of evidence-based prevention programs that SOAR can fund. And this data is from last fiscal year. So for selective, those individuals that are at risk of developing behavioral health disorder, and indicated those that have been, that are high risk with symptoms. Thank you very much for staying with us on a Friday afternoon. Really appreciate it. That was a lot of data, numbers, but I really appreciate you staying and hearing all the things that you've accomplished as a provider or managing entity. Thank you.
All right. If you haven't already, please complete the survey. Leave it on the table. We will collect those. Again, as Crystal stated, we appreciate your time today. If you need any further information about any of the presentations, feel free to reach out to me, or you can contact one of the presenters directly. Have safe travels home and have a great day. Thank you.